Before I say anything else on this video going over electrocardiogram structure, full disclaimer, I'm not a clinician. I have no clinical training. I'm not a physician. I'm not trying to teach you how to interpret abnormal EKGs. What I'm simply trying to do for anatomy and physiology students here is help you understand how to read the basics of an EKG. What are we looking at normally and what does each part of it represent? I will point out a couple places here where we can use it diagnostically, but I'm not going to get into how because that's beyond the scope of this video and it's beyond my professional scope of expertise. So let's just start by looking at an EKG, which is the tracing of all electrical activity in the heart. It's not really following a single action potential so much as it is following the spread of APs through the heart as the AP originates at the SA node and then it propagates throughout the conducting system. So on the left, we have the first waveform called the P wave, which is the portion of the EKG that represents onset of atrial depolarization. This is where atrial contraction should begin. In the middle is the QRS complex, which is really three waveforms, but they're usually so hard to discriminate from each other that they're treated as a single complex, the QRS complex, which represents onset of ventricular depolarization. So this is where the ventricle begins to contract. It's also where the atria begins to relax. There is this area of atrial repolarization happening, but we don't see atrial repolarization as a discrete electrical tracing on here because there just is so much more ventricular myocardium. The ventricular depolarization swamps out the atrial repolarization in terms of visualizing it. The third and final part of the standard EKG is the T wave on the right, which represents the onset of ventricular repolarization. So this is where the ventricle begins to relax. In addition to the three waveforms, the P wave, QRS complex, and T wave, there are a couple intervals or segments that can be used diagnostically, and it's worth knowing what they are. The PQ interval goes from the onset of atrial depolarization to the onset of ventricular depolarization. So it's essentially representing the time from when the atria begins to contract until the ventricle begins to contract. The QT interval runs from the start of the QRS complex to the end of the T wave, and it represents the time period from when ventricular depolarization begins until ventricular repolarization ends. So it's in essence from the very beginning of ventricular contraction until ventricular relaxation is fully engaged. And then here's the ST segment, which is from the end of the S wave to the start of the T wave, and the ventricular myocardium is in the plateau phase of its action potentials during the ST segment. A couple things I want to add on here just to help you see how this will connect with the mechanics of the heart in the next video series. Here is atrial systole, atrial contraction. Here is the time period of ventricular systole, ventricular contraction. And I'm kind of separating them out here because I want you to see how they relate to one another. If you look on the top of this figure, atrial systole, atrial contraction is that small period right there from about middle of the P wave until just before the QRS complex, and the rest of the time the atria are relaxing. Ventricular systole is occurring from the beginning of the QRS complex until about the middle of the T wave, and so that's where the ventricle is contracting, and then on either side of that there's this larger time period where the ventricle is relaxing. This is how the mechanics of the heart, systole and diastole, line up with the EKG. Now, in the next video set, I'm going to talk about the cardiac cycle and cardiac mechanics. Most textbooks synchronize the cardiac cycle with the EKG. I am not going to do that. I don't like it. I don't like that organization of the material simply because ventricular contraction really is what drives cardiac mechanics, not atrial contraction. And the terms systole and diastole, you can see here, systole means contraction, diastole means relaxation. Well, both the atria and the ventricles do that. When we're talking about blood pressure, which is the more commonly dealt with clinical measurement than the EKG, when we use the terms systolic and diastolic pressure, we're specifically talking about arterial pressures that are estimating what happens in the ventricles, specifically the left ventricle, not the atria. So to me, starting in mid-ventricular diastole, which is what happens when you try to synchronize with the EKG and begin with atrial contraction doesn't make as logical sense to me as starting with ventricular systole and then ending with full ventricular diastole. What you're going to find if you watch my videos on cardiac mechanics and the cardiac cycle, I don't really present anything that contradicts what you see in textbooks. I don't contradict anything that people would present with starting with the EKG, using the EKG to synchronize your cardiac cycle. It's a cycle. It's a loop. The events go in a cycle and repeat. It really doesn't matter where you begin. So personally, I find students understand it better if we begin at ventricular systole, and I just want you to appreciate that. Looking at the EKG here, that's why we're not going to be dealing with the EKG as directly in the next video series.